Hello, hello, hello. And hello, my dear friends. And how was your INI-CET paper, especially physiology questions? I am Dr. Anupama Devgan. I'm your physiology faculty in Allen Next, and I will be discussing the physiology questions. Mixed bag today, as expected, right? Students, the feedback that I've got from students is moderately tough. So let's have a look at the questions. Let's see the first question. It says, in a sarcomere, what is the order of these different bands and lines from lateral to medial? So again, this should not be very difficult. When I look at a sarcomere, what is a sarcomere? Sarcomere is the structural and the functional unit of the skeletal muscle. Between two Z lines is the sarcomere. So this is one Z line here, and this is the other Z line. Now, attached to the Z line are the thin filaments or actin, and in the middle you have the thick filaments, which is myosin. And right in the middle of the sarcomere is the M line. Now, extending from this point here to this point is the dark band or the A band. What is the A band? It consists of myosin plus overlapped actin. On either side of the A band is the I band. I band is only actin, but in a sarcomere has got half of I band plus the A band plus half of I band, because I band is in two neighboring sarcomeres. Half is in one sarcomere, half is in another sarcomere. Now, what is the H zone? H zone is on either side of the M line, and the H zone is a slightly lighter area within the A band, which has only myosin. So once again, A band, myosin plus overlapped actin. I band, only actin. H zone, only myosin. So if you go from lateral to medial, it is the Z line first, then the I band, then the A band, the H zone, and the M line. So if I look at this, I band is not in the option, so Z, A, H, M, right? So Z line, I band, A band, H zone, M line. So since I band is not in the option, so my answer becomes Z, A, H, M. So this is from lateral to medial. I have a picture here which shows the same thing. This is the Z line here. Then the I band, A band, the H zone, and the M line. So yes, most of you should have got it correct. Let's look at the next question. It says, which of the following is correct regarding the coupling mechanism in a skeletal muscle? Now, what happens in the case of a skeletal muscle? Transmission of the action potential across the neuromuscular junction. There is release of acetylcholine by the A-alpha motor neuron, which diffuses across the synaptic cleft, binds with acetylcholine receptors on the muscle fiber membrane, or what is known as the motor end plate, and then an action potential is generated. This action potential will travel all over the sarcolemma. Now, the sarcolemma dips into the muscle fiber to form the T-tubule. So the action potential will also enter into the T-tubule, and present on the T-tubule are what are known as the DHPR, dihydropyridine receptors, which in the skeletal muscle is a voltage sensor. Now, on either side of the T-tubule is the L-tubule. And what is the L-tubule? L-tubule is nothing but the sarcoplasmic reticulum. And present on the L-tubule is the ryanodine receptor, which is a ligand-gated calcium channel. So as soon as the action potential reaches the dihydropyridine receptor, there is going to be a conformational change of the dihydropyridine receptor. It is a voltage sensor. There is a mechanical coupling between the dihydropyridine receptor and the ryanodine receptor, which causes the ryanodine receptor to open, and there is release of calcium from the sarcoplasmic reticulum into the sarcoplasm. This is called excitation-contraction coupling. The electrical activity, the action potential, is going to be converted into contractile activity by the release of calcium. There is a mechanical coupling between the dihydropyridine receptor and the ryanodine receptor, which causes the ryanodine receptor to open and release of calcium. Now, which of the following is correct regarding the coupling mechanism? Does extracellular calcium have a role in the coupling mechanism? No. The skeletal muscle, the source of calcium is intracellular, sarcoplasmic reticulum. It does not depend on the extracellular calcium for contraction. Intracellular calcium plays the main role, which is true. There is no role of the calcium-gated channels. The dihydropyridine receptor is a voltage-gated calcium channel in the cardiac muscle, but not in the skeletal muscle. Dihydropyridine receptor is a voltage sensor. Dihydropyridine receptor in the cardiac muscle is a voltage-gated calcium channel. Since the question says skeletal muscle, so my answer here becomes B. Intracellular calcium plays the main role. And that is why calcium channel blockers do not affect the skeletal muscle. Calcium channel blockers will affect cardiac, smooth muscle, because both cardiac and smooth muscle, the source of calcium for contraction is ECF. But for the skeletal muscle, the source of calcium is intracellular, sarcoplasmic reticulum. Let's have a look at another question. This was an equilibrium potential. Unfortunately, I do not have the options. I just know that there was a question, assertion reasoning question on equilibrium potential. So the key points about equilibrium potential is calculated by the Nernst equation. Second key point about the equilibrium potential, this is for a freely diffusible ion, for an ion which is freely moving across the cell membrane. Equilibrium potential is calculated for freely diffusible ions. A cell membrane has to be freely permeable to that particular ion. Only then we can calculate the equilibrium potential. Equilibrium potential is the potential when there is no net transport of the ion. The movement of ion has stopped. The potential difference created due to the movement of a freely permeable ion is known as the equilibrium potential or the Nernst potential. This is given by the Nernst equation. And what is the equilibrium potential in the case of potassium? This is minus 90 millivolts. Some books say this is minus 95 millivolts. Equilibrium potential for chloride is minus 70 millivolts. Equilibrium potential for sodium is a plus 61 millivolts, and equilibrium potential for calcium is plus 125 millivolts. The important point is these equilibrium potentials are calculated when the cell membrane is freely permeable to these ions. So I'm not very sure about what were the assertion reasoning, what were the options, but I've discussed the what are the key points as far as equilibrium potential is concerned. And I will be giving you my email ID at the end of this discussion. So whatever you can think of, if you do remember the options, please send them across to me. All right, JAK-STAT regulated hormone secretion. Now, as far as aldosterone is concerned, aldosterone is a lipid-soluble hormone. It has got intracytoplasmic receptors. Calcitonin acts via the cyclic AMP. Second messenger for the action of calcitonin is cyclic AMP. For vasopressin, there are three receptors, V1, V2, and V3. V2 uses cyclic AMP as the second messenger. V1 uses the membrane-bound phospholipase or inositol triphosphate as the second messenger and calcium as the third messenger. V3 also uses inositol triphosphate and calcium. Leptin acts via the JAK-STAT pathway. Now, this is something which this particular topic is asked again and again. The second messengers for different hormones, and you must remember which are the second messengers. This is an extremely important slide. Last year's question was on catecholamines. What is the second messenger for catecholamines? This time, calcitonin was in the option. So calcitonin uses cyclic AMP. ADH V2 receptor uses cyclic AMP. Cyclic GMP, ANP, and BNP, atrial natriuretic and brain natriuretic hormone. Phospholipase, second messenger, ADH, V1 and V3. Hormones which do not need second messengers are growth hormone, IGF-1, prolactin, leptin. They act via the JAK-STAT pathway. Insulin also does not need a second messenger. This is because the insulin receptor itself has tyrosine kinase activity. So this is an important list that we must try and remember. Right, CFTR, this should be a very, very easy question. The cystic fibrosis transmembrane conductance regulator is which of the following? And that is a chloride channel. This should not have been difficult at all. Match the following was asked. Now, again, I do not know the options, but I can possibly guess the options. The functions of these hormones was asked. Now, gastrin will increase the HCl secretion. Secretin causes an increase in the bicarbonate content in bile and pancreatic juice. Motilin, this increases the gut motility. This is also responsible for what is known as the migrating motor complexes. CCK causes gallbladder contraction, which is also known as a Cole-Gog action. And it increases the pancreatic enzyme secretion. Gastrin secreted by the G cells in the antrum, secretin by the S cells in the upper small intestine, motilin by the M cells, CCK by the I cells. So I think it should have been hormones and their actions. Relaxation pressure is zero at which lung volume? Now, relaxation pressure is zero at FRC, functional residual capacity. What is functional residual capacity? Lung volume at the end of a normal expiration. In fact, the functional residual capacity is also known as the relaxation volume of the lungs. Now, for this, you have to look at the relaxation pressure volume curve. This is the pressure in centimeters of water is given on the x-axis. This is also known as the transmural pressure. And the volume, in this case, it's percentage of vital capacity, which is given on the y-axis. Now, this one here is the transmural pressure of the chest wall. The solid line, there's another dashed line, which is the transmural pressure of the lung. And the solid line is the chest wall and the lung, the transmural pressure of the respiratory system. And if you can see this over here, at FRC, the pressure of the respiratory system, the transmural pressure in the respiratory system is zero. At FRC, why is this pressure zero? Because this is the sum total of the slightly negative pressure of the chest wall and slightly positive pressure of the lung at FRC. So this is the pressure here is 0 at FRC. And like I said, FRC is also known as the relaxation volume of the lungs. Now, which of the following is the correct order of auscultation points on the left side of the chest? Now, as far as left side of the chest is concerned, aortic is on the second intercostal space on the right side. Left side, second intercostal space. Left side is the pulmonic area. Tricuspid is the left lower sternal border in the fourth intercostal space. And in the fifth intercostal space on the left side in the mid-clavicular line is the mitral area. So superior to inferior on the left side, pulmonic, tricuspid and mitral. So my answer to this question would be pulmonic, tricuspid and mitral. Remember, aortic area is on the right side. So this is the answer to the question. Now, which of the following is a function of the smooth endoplasmic reticulum? Smooth endoplasmic reticulum, this is something which you should remember from your school level knowledge also. This is involved in steroid synthesis. Let's see, Wind-Kessel effect. Now, what is Wind-Kessel effect? Now, when the heart pumps blood into the aorta and the large arteries, aorta and the large arteries are very rich in elastic tissue. They have a high content of elastic tissue. So what happens is that the aorta and the large arteries tend to expand. This happens during systole, when the heart pumps blood into the aorta. But during diastole, there is no force from the heart. So what happens to the aorta and the large arteries? They tend to recoil. It is like if you take a rubber band, you stretch a rubber band, there is a tension which is generated, you leave the rubber band. It will recoil to its original size and shape. So, during diastole, because of this elastic recoil of the aorta and the large arteries, this literally squeezes the blood and pushes it forward. That is why, even though there is no force from the heart during diastole, the circulation does not stop during diastole. It continues in diastole. And the main reason for the diastolic blood pressure is this elastic recoil of the aorta and large arteries. And that is why this is known as the Wind-Kessel effect. And the aorta and the large arteries, which have a high content of elastic tissue, are known as the Wind-Kessel vessels. Now, out of these, Wind-Kessel effect is not shown by which of the following? The central arteries, which will have a larger content of elastic tissue. But as you go away from the heart, the elastic tissue is replaced by muscle tissue. So the elastic tissue content reduces, muscle content increases. So aorta, subclavian, common carotid artery will definitely show the Wind-Kessel effect. So here my best answer becomes radial artery. Okay, yes. So some of you seem to have got it correct. Okay. All right. Now, this was an interesting graph. Now, this says the following graph is seen in which of the following types of hypoxia? So we must have a thorough understanding of the hypoxia. Plus, I always say this, that whenever you get a graphical question, first see what is on the x-axis and then what is on the y-axis. The x-axis, now what I have been told in the recall by one of our students, that on the x-axis we had PO2 in millimeters of mercury, and on the y-axis was not saturation, but in fact oxygen content per 100 ml, right? So now, this is a normal graph here, yes? Normally, the PO2 is about PO2 in the arterial blood and venous blood. PO2 in the arterial blood is 95. Venous blood is 40 millimeters of mercury. saturation is 97 to 98%. Venous blood is 75% saturated. But if you talk in terms of oxygen content, in the arterial blood, it is 19 ml per 100 ml. In the venous blood, it is 14 ml per 100 ml. So here in this particular graph that was given to you, the oxygen content in ml per 100 ml was given, not the saturation. Right? So if this is arterial blood, PO2 95, oxygen content about 19, and in venous blood, PO2 40, content 14 ml per 100 ml, as you can make out over here. Right? So this is normal. Now, this was the abnormal graph which was given. So what you can see over here is, in this abnormal graph, the PO2 is normal, but the oxygen content is reduced. And the venous side, the PO2 is, this is in the arterial blood, sorry. This is the arterial blood. Venous side, there is a reduction in the PO2. PO2 is less than normal, less than 40. And there is also a decrease in the oxygen content. Right? So which is this type of hypoxia? The oxygen content is reduced in the arterial side as well as the venous side. Now, what is going to happen in, let's take these hypoxias one by one. In anemic hypoxia, there is a decrease in the oxygen carrying capacity of the blood, or there is a decrease in the oxygen content, but the PO2, arterial PO2 is normal, right? So it could be anemic hypoxia here. In histotoxic hypoxia, there is a very large increase in the arteriovenous oxygen. Sorry, there is a decrease in the arteriovenous oxygen difference. Why? Because in histotoxic hypoxia, the tissues are not able to utilize oxygen. So normal arteriovenous oxygen difference, which is 95 PO2, 40 in the venous side, oxygen content 19 ml, and 14 on the venous, this difference will increase. In hypoxic hypoxia, there is a decrease in the PO2, right? There is a decrease in the PO2, there is a decrease in the saturation, there is a decrease in the oxygen content in both the arterial and the venous side. And stagnant hypoxia, there is an increase in the arteriovenous oxygen difference. Why? If there is a stagnant hypoxia, since the blood is moving slowly, the tissues will extract more oxygen. So the difference between histotoxic and stagnant is, in stagnant, increase in the arteriovenous oxygen difference, in histotoxic, a decrease in the arteriovenous oxygen difference. When do I call it hypoxic hypoxia? Decrease in PO2, decrease in saturation, decrease in oxygen content. When do I call it anemic hypoxia? Here the PO2 is normal and the oxygen content is reduced. And as you can see in the graph that I've shown you over here, or the graph that was given to you, and hopefully this is the graph, the PO2 on the arterial side was normal, but the oxygen content was reduced. Remember, oxygen content refers to oxygen, dissolved oxygen, and oxygen in combination with hemoglobin. In fact, on the venous side also, there is a decrease in PO2 and decrease in oxygen content. There is a larger arteriovenous oxygen difference. This points towards a anemic hypoxia. Normal PO2 on the arterial side, but a reduced oxygen content. Venous PO2 reduced oxygen content, larger arteriovenous oxygen difference. But remember, the characteristic feature for anemic hypoxia, arterial PO2 is normal, but oxygen content is reduced. Histotoxic, why is this not histotoxic hypoxia? In histotoxic hypoxia, arterial oxygen content will be normal, but arteriovenous oxygen difference will decrease. Stagnant hypoxia, arterial PO2 and oxygen content will be normal, but the difference will increase. Histotoxic, decrease. Stagnant, it will increase. In hypoxic hypoxia, arterial PO2, saturation, oxygen content, all will reduce. So, same thing here, but what is the difference here? Here you have PO2 on the x-axis and saturation on the y-axis. Right side you have oxygen content. So you have to be very careful. The graph which I've been told, which was given in today's INI-CET exam, had PO2 on the x-axis and oxygen content on the y-axis. If that was the question which was given to you, then this was anemic hypoxia. This was shown as a normal graph, and this was the abnormal graph. Why is this anemic hypoxia? Once again, arterial PO2 normal, total oxygen content reduced, venous PO2 reduced, venous oxygen content reduced, greater arteriovenous oxygen difference, pointing towards anemic hypoxia. So, should not have been too much of a problem, provided if you study the graph carefully. Always when you get a graphical question, please look at the x-axis and y-axis. Yes, understand the graph and then try and answer the question. So these were your INI-CET recall questions. There are, let me give you my email ID. I'm Dr. Anupama Devgan at gmail.com. You can also send me a you can get in touch with me on Messenger. My Facebook page is Dr. Anupama's Physiology. Looking forward to hearing from you, and all the best for the result. Thank you so much, and God bless.